betrayal. You got me running, you got me running, got me running. Shake it, shake it, shake it, baby.
I am Meredith Hirsh, along here with Mike Chavez, and this is Working Healthcare, the podcast where we talk with the people on the front lines of medicine about what's working, what's broken, and what needs to change.
Today, we're digging into a conversation that's becoming impossible to ignore: burnout. But what if what we're calling burnout isn't actually the full story?
Our guest today believes it's not burnout at all. It's moral injury. That's the distress clinicians feel when they're forced to compromise their values, especially their commitment to putting patients first.
Joining us is Dr. Wendy Dean, a psychiatrist, author, and the co-founder of the nonprofit Moral Injury of Healthcare. She's spent the past several years amplifying a message that resonated far beyond what she expected, starting with a single opinion piece that struck a national nerve.
That article led to her book, If I Betray These Words, where she writes, "The system is not broken. It's functioning exactly as it was designed, to make money. But that system is grinding our best and brightest into dust." And Wendy knows that firsthand.
She left clinical medicine in 2010 after trying every business model she could think of, from private practice to leading psychiatric care in one of the largest hospitals in the country. She told us, "I believe strongly that doing therapy and medication management together is the most effective way to manage patients." But the system didn't support that. Insurance reimbursement was low, and ethical care, too often, came second to financial concerns.
And the numbers speak for themselves. According to a 2024 survey from the American Medical Association, nearly 50% of physicians report feeling burned out. Even more telling, 40% have considered leaving medicine, and 14% plan to leave within the next 2 years. Wendy says every physician thinks about leaving, but it's when they start making a plan, that's when they really go.
We'll talk with Wendy about how corporatization is reshaping healthcare, why it's essential for young physicians to understand the business side of medicine, and how we begin to reclaim what she believes medicine was always meant to be: a calling, not just a job. If we want to lead real change, Wendy says, clinicians need to start betting on themselves, not just to survive the system, but to transform it.
Whether you're a provider, a patient, or someone who just wants to understand what's really happening behind the scenes of healthcare, this is a conversation you do not want to miss. Wendy, welcome to Working Healthcare.
Thank you so much. It's great to be here.
I was introduced to you by Mark Craig. I was very excited about that. His episode aired a few episodes ago. And I said, I really need a strong female advocating on the front lines of healthcare. And he's like, let me introduce you to Dr. Wendy Dean. So here we are.
And here we are.
So
This is great.
I'd love to hear your story. I just had some students on the podcast who are going into medicine. A lot of them doctors, physician assistants, one researcher, one looking at private equity, or at least finance. I know that's the big naughty word. But I wanted to hear what this Gen Z, these Zoomers, really thought. Why did you choose to go into medicine? I want to start at the beginning.
So I wish I had a more articulate answer. I don't have a good one. It was something that I decided when I was in about fourth grade. And I had people who told me, if there's anything else in the world that you can do that. An orthopedic surgeon who was a neighbor of ours when I was growing up. And so I kept looking for other things that I would like to do better and just kept coming back to medicine. I was fascinated by the science of it. I was fascinated by the interactions with people. It just all seemed to fit.
That's so crazy. So back in whenever you grew up, because I think you and I are about the same age, people were forcing us into medicine. I know that I went and took calculus in college just to think, maybe I'll go to medical school. Maybe that's the track. And I quickly realized I knew I never wanted to go to medical school. So it's interesting that you say that. But then you went to medical school, you went through crazy training, and then psychiatry. Why did you choose to study psychiatry?
Oh, that was my path. Well, no, I mean, that wasn't the original path, I should say.
Okay.
So I started my residency in surgery and did that for a couple of years and quickly realized that that wasn't really going to give me the opportunity to do all of the things that I like to do. Because you have to really be committed to that lifestyle. So I went and worked in emergency rooms for a couple of years. That let me see and it was in rural Vermont and New Hampshire.
So you had
So we
already
saw
done
everything.
your entire residency in surgery?
No, I I did 3 years and thought, I can't.
Oh my,
If I'm not
Interesting.
gonna do this for a living, I need to cut bait and get out right now.
see, you are a super strong woman. Man, women in surgery, especially when several years ago, right? That had to be an interesting experience. It's very male dominated.
Correct. But I mean, it's okay with me.
Yeah, no, you're strong.
Uh,
You're
I
alpha
grew up
strong.
I grew up with a brother who was 6 years older and 50 pounds heavier than me at all times. You know, I learned how to hold my own.
So you knew how to fight them off. And then
Or
how'd you
fight
end up in
back.
psychiatry? Yeah. How'd you end up in psychiatry?
So I was in these rural emergency rooms where I was the only physician on shift, and so everything that walked through the door, I managed, and it let me see the whole span of what healthcare is. And I'm somebody who is sort of temperamentally averse to boredom. And I felt like psychiatry was one of those things where it's a black box. Like it, we don't know enough about it for it to be boring. And so that's it. Sort of human behavior has always fascinated me, and that's what I did.
So you practiced as in psychiatry for several years, and fast forward, when did you start to feel that medicine wasn't working the way that it should?
Oh, that started in my
When you were in
surgery
fourth grade?
residency.
No.
Yeah, I mean, it was one of those things where when I was calling the insurance company to get permission to admit a patient overnight, and that's when prior authorization was pretty restricted. But we were calling to get permission to admit our patients overnight. And I thought, there is something fundamentally wrong with business folks making this decision. Um, and it didn't get better as I went on.
So you felt like this was happening 20 years ago. How has it escalated to even now? Do you feel like it's amplified, gone up twice as much, 5,000 times as much?
I mean, I can't put a number on it, but I would say that all the governors are off, and insurance companies are putting prior auth on whatever they choose. Because when I was in my residency, 80% of physicians were self-employed.
Mm-hmm.
They could choose to leave the network if things got too bad. But now 80% of physicians are employed, right? So 80% were independent, could choose to walk away. Now 80% are employed. They don't get to choose whether they walk away. Their employer gets to choose what networks they're in.
Why do
And
you,
so
no, go ahead. I'm
go ahead.
sorry. I'm
No, so
sorry.
the insurance company no longer has an incentive to be careful about how much they harass physicians for prior auth.
Why do you think the shift happened from the 80 in private practice to the 80 working for somebody else and as employed physicians?
Our reimbursement structures that no longer make it sustainable to be in private practice for the most part, or at least that make it really challenging to be in private practice. Um, when you can't make overhead, you have two choices. You close down and walk away, you quit and find a different job outside of medicine, or you sell out to the hospital down the street so that you can at least keep the doors open.
Was it private practice first for you and then the hospital, or the reverse?
It's the other way around.
Okay.
So I came out
So,
of residency
yeah.
and was the director of the emergency psychiatry services in the emergency room of a large urban hospital, and then left there about a year later to go into private practice.
Why did you leave? You shared with me a story as to why you left. If you can share, Mike actually didn't hear this story. Could you share with us why did you make that pivot?
So there were a couple of reasons. One of them was that uh, the payment structures and the payer mix that we had in that area were challenging. And so I was being asked to stabilize and transfer if the reimbursement that we were going to get wasn't sufficient. That went against what I believed was best for my patients. And when I couldn't shift that mindset, I mean, I was junior. I was in my first year out of residency, right? I had no power. I had no authority. Um, but when that became very clear that I couldn't be effective, I decided to leave. I also, you know, it was the beginning of realizing that, I could only carry a few of my own private patients because I couldn't bill sufficiently the way I practiced to make it worth the hospital's while for me to do psychotherapy and medication management.
You actually shared with me, and I can attest that it's a really great idea. I've raised three children. My mother's a social worker. I feel like I've lived in the world of psychoanalysis. Being able to combine the medication treatment and the therapy is really crucial. And you were sharing with me the reimbursement by the insurance companies is so subpar as a doctor providing therapy. I know that even in Florida, South Florida, to let you know, to find a child psychiatrist is impossible. Okay. You will never get a child psychiatrist who takes insurance. You will always have to pay out of pocket. And then if you go out of state, and I've experienced this in Utah, that there are so many fewer psychiatrists, and you now have PAs practicing and working for these psychiatrists. So the system is escalating. It's this crazy snowball effect because of insurance. Share with me the reimbursement structure for insurance and why psychiatrists are really financially unable to take insurance.
Yeah, so psychiatrists they can choose to take insurance, but typically the setting in which you'll do that will kind of funnel you into medication management only.
Mm-hmm.
That for me wasn't a satisfactory way to practice. It also I didn't think was the best for my patients. So when you do psychotherapy and medication management together, you to me it's a more finely nuanced way of practicing. And my patients responded very well to it and typically got better relatively quickly. But for the days that I saw my patients for psychotherapy alone, because not always did they need medication management, um, I would get reimbursed about $60 for the visit at most. And that was because they reimbursed psychotherapy for all licensees at the same level. So it didn't matter whether the therapist was a social worker or a psychologist, PhD prepared psychologist or a physician, we all were paid the same. If I did medication management, there was a small bump in the fee, but it was never enough to cover my overhead because my overhead was significant. It was like orders of magnitude different than say, the malpractice liability coverage that a social worker carries. And that's just a fact. I'm not trying to be disparaging at all. It is just a matter of numbers.
Well, physicians graduate their training with an average of $300,000 in debt. Social workers do not have that. My mom is a social worker. I know how much my mother makes, and I know that because I had to go through the prior authorization process for medication and to get coverage or patient assistance. So I know what that threshold is. My mom makes very little money to be able to, and she does therapy, and she's a marriage and family counselor, not medication management, obviously, but she has her master's in social work. And so comparing that to a physician who has now delayed gratification or starting their life, right? Being able to save anything because they've been in school for so many years, and then going into practice and getting paid like somebody who has a bachelor's degree or bachelor's degree and maybe an additional year, and you have $300,000 in debt. How is that sustainable?
It wasn't.
Right.
I mean, the truth is, it wasn't, which is why I left.
Who thinks this is a good idea? This is what I'm so frustrated, and I know I sound so passionate right now about this, because I really think a huge issue right now in America is the lack of mental health resources. There's nothing in my state, unless you're addicted to drugs. I swear, this is like the drug capital of the world for mental health. But other than that, there's nothing. There are no resources specifically for children. And I have people who reach out to me all of the time, and they're at a loss because they don't know where to go, who to turn to. I know about Utah because I know that there are several programs in Utah, but Utah doesn't even have psychiatrists. And I'm sorry, I don't want a PA managing the medication for my child. And I would like my child to see someone who has more education and more experience, specifically on the medical management side. Who thinks this is sustainable? Why is this happening?
Great question.
Right.
I mean,
that was one of my
just
questions.
to,
Is I probably know, sorry to interrupt you, but I probably know the answer, and we probably think we know the answer to this, but I want to get your perspective. Dealing with insurance companies is across the board becoming more and more difficult, and it has been for you. What do you think the driver is this for? Do you think it's strictly financial, or what do you think the driver of that is? So along the same lines as her question is, who thinks this is a good idea, and why are they doing it? Because it's not sustainable.
It's certainly not the psychiatrists. I don't think there's anybody in mental health who thinks this is a good idea to have half of the counties in the country without a psychiatrist. And even the counties that do have a psychiatrist, half of them don't take insurance.
Mm-hmm.
So access is a big problem. And the only thing, chapter 5 of If I Betray These Words is about psychiatric care in the US. And it boils down to, we have never committed to resourcing mental health care, behavioral health care, as we should. And we have allowed insurance companies to carve out mental health care, to have disparate payment between physical care and mental health care. There are laws on the books that we don't hold them accountable to. So we could just start there.
And my husband was just in DC actually advocating with the American College of Rheumatology. And while we think we're making progress and we're there are lobbyists from the insurance companies who are spending millions upon millions of dollars to be there 24/7. And my husband had to not see patients for 2 days so he could go up to Capitol Hill and hopefully speak to some of our congressmen. How can we as physicians or the healthcare community have an impact? Because you're doing it in your group. I'd like to know how we together cumulatively can create an impact.
Yeah, so I think there are a couple of answers to that. Number one is we can't do it alone. So physicians are trained to be fiercely independent And it serves our patients well. It serves our practice well. It does not serve these sorts of things well. So we need to learn to come together, to support each other, to support the organizations that are doing this hard work. And whether that means with your time or with your money, you need to throw in support because otherwise they go away. That's one thing we need to do. We need to learn how to do that, how to speak the stories in ways that our legislators can hear. We need to take the time to go and educate them. It's not lobbying, it's education, because we take what we do for granted because we've done it for years or decades. We think it's self-evident to everybody else, but what we do and why these changes matter to us is very opaque to the rest of the world. So we need to make sure that we are taking the time to explain why these changes are necessary and important, not only to us, but also to our patients. And we need to find a way to pull patients into this as well,
I
to help
definitely
them understand how they can advocate for us with us for change. We're all on the same side.
I definitely agree with you. I always say, people are like, are you working or fighting for patients or are you fighting for doctors? I said, it's one and the same. If I support patients, I'm supporting doctors. If I support doctors, I'm supporting patients. And so what frustrates me is every year at my annual conference, it's an advocacy conference, the Coalition of State Rheumatology Organizations, and it is filled with private practitioners in rheumatology, but they're not just rheumatologists. They're also people like me. Every year there are the same people, and there are about 100 of us. And I have stood at conferences in my speaking. I always give my little plug about joining organized medicine, being a part of these groups, and nobody ever takes me up on it. I'm going to let you know in the last year and all the talks I've done, one person took me up on it as a repeat. So I didn't get anybody new. And I feel, is this futile? Or can we really, with these doctors who are so highly independent, can we create this change?
So I think one of the things that we haven't been as good at as we should be, and I think we're really good at describing the problem. We're less good at helping people see the bright future that we're heading towards. And that's really what we need to get better at. And we're making a push to be solutions focused, to do positive inquiry instead of negative. And you know, I will say that sometimes sometimes in doing that, people are like, yeah, that can't work. I'm like, well, let's just wait a minute. Let's see. Because I think it can.
So what can work? What is that solution?
Oh, um, so I think one of the things that we need to do, and of course, you know, folks, I've talked to a lot of folks and they're like, oh, that's not going to happen. We need to get rid of prior authorization.
Mm-hmm.
We need to get our federal agencies to harmonize their requirements and reduce their requirements. We need to, and you know, to sunset the ones that really don't matter anymore.
Mm-hmm.
We need to find ways to hold the business side of healthcare accountable for the administrative harms that inevitably occur. I'm not going to say they're intentional. I do not think they're intentional. Nobody gets up in the morning intent on making people miserable and making patients' outcomes worse. But there are unintended effects that we need to still hold people accountable for.
Can insurance be privatized, or do we need to move to a government-run insurance? And the reason I ask you that, based on your answer, is if insurance is geared towards the shareholders and you're always looking to increase the net profit and to increase the stock in which is associated with your company, is it possible to have these independent insurance companies?
We did for a long time. They were all nonprofit. There's a point at which we allowed health insurance to become for profit, and that's changed a lot of the game. And maybe we need to rethink that. And maybe we need to rethink vertical integration and horizontal integration so that we have organizations that are truly independent, that aren't able to play the shell game of moving money around within their organizations to maximize their profit.
I want to go back to something you just said, because I think that you pointed something out that's actually a brilliant idea, which is holding the business side accountable. So how would you do that? By penalizing them for the issues that they're causing? Is that how you see it happening? Because I think, if you could do that and figure out how to do that, even in the smallest way, that would make an impact. And I think that's a brilliant idea, actually.
Yeah. So there's a bill in Washington state where they want to license the administrators in healthcare. If you think about that, if you license, and I talked about this in the book, is we really need to hold the administrative side of healthcare accountable. So if we had to license, if the folks on the administrative side had licenses, then we could have a parallel accountability structure to what physicians have, right? We have the National Practitioner Data Bank. If you behave badly, you go in there in perpetuity. So why don't we have one of those? Why don't we have a national executive healthcare data bank or healthcare executive data bank?
So I'm going to ask you a little bit more about this, because I know when you and I first talked, you were like, sorry, but it's the MBAs that are screwing it up. And I disagree, because, and this is a struggle that I have when speaking to my doctors and all of my providers. I still have a company that I have to run, and I'm held by the insurance company. So the documentation that I need is based on the requirements by the insurance company. The information I need, yes, prior authorizations should cease to exist. But whether it is a denial and we have to fight it, right? Or it is a prior authorization, or it is just documentation, because down the road, we will always get audited, right? Medicare runs audits often, especially for level 4 office visits. That's their favorite right now. And it's still important for me to give them staff. I need to hire nurses and medical assistants and people to answer the phone. And I have more prior auth people than I've ever had in my entire life. And it is obscene. I have infusion that I have to staff for. I have principal care management now. I have to pay these people. I pay the most people I've ever paid in my life yesterday. 55 people on the company payroll, not including anybody I outsource, which is crazy. So then I try to explain this to my doctors. So as administrators, I'm just sort of the bridge between the insurance company, so we get paid, and the doctor.
Right. Yes. And I'm not saying that it's just the administrators in the hospital or in the health system. It's also the administrators in big pharma. It's insurance companies. It's private equity. If you step foot into the house of healthcare, you ought to have a license if you're going to be making decisions that are going to impact the front lines.
Right.
So you notice that I didn't say that's the only solution. The other solution is that we need to get rid of prior auth so that you can get rid of, you can streamline your workflow. We also need to harmonize and reduce the number of requirements for CMS, and we need to hold the insurers accountable for, why are you asking for all this information, right? So I'm not saying that we need to license folks and hold them accountable in isolation. There are other things that we need to do. This needs to be sort of a whole of healthcare rethink.
Yeah, I think what may happen is that if you start to make those changes, there will be a trickle down, or rather like a trickle up, where when you start to hold administrators accountable, you'll realize that some of the burden falls on the insurance companies. Therefore, you start to pass some of that accountability onto the insurance companies. So hopefully that's what would happen, or that's what would be a result, is like a triple up effect of holding people accountable, which I think would be a great scenario.
Yeah, like let's just look at Crozier Health. for one example, a community is losing two of its hospitals. It lost two other of its hospitals in the same system 3 years ago. So this entire health system has collapsed under the weight of some pretty sketchy financial management. The folks who set up Prospect Health were bad actors before that. So, you know, they had bad outcomes in one organization, and they were allowed to just set up another organization and do it again. That needs to stop. When I was writing If I Betray These Words, I kept finding the same names over and over again. They would do unfortunate things. They would disappear for 2 to 3 years and they would pop up somewhere else. Physicians, when that happens, get put in the National Practitioner Data Bank. When you hire a physician, you have to search the National Practitioner Data Bank, right? Why aren't we doing that across healthcare?
Yeah.
I would like to do that more for those larger companies. I would say that you have to have some type of exemption for the small independent practice, because then
But physicians don't get that exemption. Why should administrators?
I worry though with the physician with the healthcare shortage that we're going to have even a larger problem, and the amount of money we would have to pay other people. And I don't know where, maybe it's just me.
So
Maybe
should we exempt physicians who are employed because they're not making all of their decisions? They don't have the responsibility and the authority and the agency to be able to make decisions about how they deliver care?
I think 100% there should be a database, almost like an ethical database, that if somebody is doing something wrong or has a mark against them in the way that they are behaving or administrating, but going and requiring them to get some type of certification or accreditation, I think is going to limit those who are able to go into the field greatly, or it's going to limit smaller practices' ability to pay for people, and they're going to disappear entirely. I'm just
Maybe
fast
you just
forwarding.
put it at the executive level.
Yeah, I think
that's fine.
there's a mix and balance, and to your point, I think that you can't overcorrect so much that you're going to cripple a profession, because then it's going to have a negative effect. So I think it's probably a balance of both, but at least passing on some burden, not so much that it would hurt the industry, but at least some. So there's some more accountability outside of just the clinical side.
And I want to go specifically to your book. You've written, I love my patients, but my job is killing me. What does that line mean to you now? And why did it strike such a chord with you when you wrote those words?
This is what I hear from physicians every single day. Every single day. It was true for me a decade ago, 15 years ago. It's true for physicians now, maybe more than it was then. And it's this sense that I was educated and trained for more than a decade to know how to take the best care of my patients possible. And there are so many constraints in our healthcare systems that I am practicing with both hands tied behind my back. That is asking me to go against what I promised society I would do. It's an untenable way to live a life and to have a career.
And you've said burnout is only part of the story, and you call it moral injury. Can you share what that other part is?
Yeah. So, so we've actually done some research that shows that burnout and moral injury are in fact both separate experiences. So it's not one or the other. I will say that our first article in Stat News, we did not get to choose the title, and we've been fighting against that title since day one. So, it's not burnout, it's moral injury. Okay, not really what we meant. So burnout we see as the transactional challenges, the transactional operational challenges of healthcare that are too many patients, too many tasks, too much documentation, right? We need to harmonize those requirements so that we don't have as much of that. That is a very real thing. At the same time, there's a very real sense of betrayal by a legitimate authority in a high stakes situation that causes you to transgress your deeply held moral beliefs. And that is the moral injury part of it. I promised society that I would care for patients to the best of my ability, absent self interest. And yet, every day, I'm asked to think about the hospital's balance sheet when I am referring patients, when I'm ordering tests, when I'm deciding how to care for them. How do I reconcile those two? So there's the transactional piece, which is burnout. There's the relational piece, which is moral injury.
When you first wrote that article, what was the response that you received?
Oh, it was unexpected. So Simon Talbot, who's my co-founder, he and I wrote this article because we'd been bouncing this idea back and forth for about 9 months. And it just really seemed like the people that our close friends that we kind of ran it by, were like, yeah, wow, that's it. And so I was in a new job and we felt like, okay, we just need to wrap this up, tie this up with a bow, and then I can be done and move on with my job. And so we published the paper and it blew up. We thought it would go in the bin with all of the other burnout and well-being papers. And it was published in July of 2018. It was the most read article for Stat News in 2019. These things usually die in 6 weeks at most. It became, within a couple of years, it became one of the 5 top read articles for Stat News ever. And this isn't a way to say that we were smart. This is what it says to me, is that it powerfully resonated with what people were experiencing. The most common thing that people said was, I've been looking for this language for years. This is what I'm experiencing. So people were hungry for a different way to express what their experience really was.
How did it feel seeing your inbox fill up with all of these messages from your colleagues?
Well, it's such a unique perspective to burnout, because even if you can search burnout now and it's not listed as a cause or a result, or even with burnout when you just Google burnout. So it's such a unique idea. And that's probably why it really resonated with everybody and was read. So, even to me, when I was doing the research, I thought to myself, this is such a unique perspective on this.
Yeah. So it is. It is comorbid with burnout, but it is not of burnout. It is not connected to burnout. It doesn't.
Right.
It doesn't come from burnout. It doesn't lead to burnout. It is. They may influence each other, but they are distinct experiences.
So you don't think one is the result of the other or the reverse?
No, sir.
Interesting.
That's not what the empirical data is showing. They do influence each other, but they are separate entities.
See, I keep going back to what you and I have talked about this, Mike, about just do the right thing, right? If you do the right thing, good things will happen. You will reap the benefits. But I will tell you, Wendy, I think that people convince themselves that what they're doing is right, even though it's wrong. And I had a conversation with someone yesterday who said, well, but isn't it just lack of knowledge? And I said, I'm going to say the same thing CMS says. Your lack of knowledge does not constitute incorrect delivery or bad billing or not following the rules. You need to go seek out that knowledge. So looking at it from that perspective, do you think that people just convince themselves that what they're doing, the CEO of United Healthcare, horrible situation, obviously, Brian Thompson being gunned down, but do you think that he convinced himself that what he was doing was the right thing?
I think there are powerful incentives to convince yourself that you're doing the right thing. Absolutely.
Do we change
Yeah.
that at a base level? I'm asking you as the psychiatrist and this amazing, powerful person. But do we change that as we're raising our children? Who's responsible for that? Are those parents' responsibilities? Is that societal? Is that society's responsibilities? Is that teachers' responsibilities? Like, who holds that?
Yeah, it's interesting. I was just talking with an author last night who's, when my book was reviewed, the Kirkus reviewers put our two books together. So Brian Alexander wrote The Hospital, and he's in the middle of writing another book about Chester, Pennsylvania, and the Crozier health debacle happens to be part of his story. So we were talking last night, and he's written some amazing other books, The Glass House, The Hospital, and across all of those is this sense that we have lost the fundamental connection between people, sort of the moral compass. And we've let profit become the thing that we all believe is sort of the be all and end all. Until we decide that there's something more important than profit and making more money than everybody else in our neighborhood, we're going to struggle to get to a place where we are able to care for people according to their values rather than our organization's values.
So how do we make that pivot? Because you said when you were in fourth grade and wanted to be a doctor, everyone was convincing you not to do that. And there was an orthopedic surgeon friend of your family's who said, don't go into medicine. Why did he tell you not to go into medicine?
Because medicine is a hard life. And at that point, he was newly out of residency. He was building his practice. It was all hours of the day. When you bet on yourself, it's a tough bet, right?
Yeah,
But
you have to have that confidence. It definitely is a tough bet. But I'm
when
thinking,
and you have to have a work ethic that also is, in my own practice, in my own organization now, like it is not 9 to 5. It's
oh,
not 9 to 5.
it's not nine
But
to five for me.
there's also a deep gratification being able to take care of people the way you were trained to do, to make your own decisions about how that practice goes, how you care for patients, where how you meet them in their lives. That's not dictated by corporate policies.
And I think it's interesting, though, that you said the reason why you were told not to go into medicine is because of the really tough, crazy lifestyle. So I have 3 sons, and I know you have 2 kids, and neither of your kids are doctors, and none of my kids are studying to be a doctor. One's graduated college already. Oh my gosh, no desire. The middle one, and my youngest was questioning it, and his entire family is filled with doctors, and he still has it in the back of his mind. Maybe he's double majoring in math and neuroscience, but he actually thinks he's going to go the finance and administrative route. And the reason why is because he's going to work so hard, have such delayed gratification, and then work for somebody else.
Right. Right.
How do we change this? How do we change this? Because
We
you've
support
also
private practice. We change legislation to get rid, to bring back psych neutral payment, to allow physicians to run hospitals. Like those changes that are fundamental to allowing us to practice the way we were trained to do.
and this is the long game, because this is not
Correct.
going to happen overnight.
There's no short game here.
Right.
There's
Because
no short game.
because you've also said it has to be a calling again, and it's not a calling anymore. But do you think this generation is capable of having it be a calling?
Of course. But we need to show them. We are not, we're showing them everything that's wrong. We're not showing them what it could be, what it was at one point. And I think we need to get better at that.
And is
So that's part of what we're trying to do. Part of the reason I wrote the book was because I wanted to tell people where we are, but also how we got there. Because when you're renovating a house, it's a lot easier when you know what the blueprints looked like,
mhm.
right? So if we know how we got here, we'll know how we can undo it. And the reason I started 43cc podcast with Matt Ramsey, who's an orthopedic surgeon, is because we realized that there is a big gap, right? We have to help the younger generation see that medicine can be different. It can be different. We, as hard as medicine has been, we still love it. I don't practice anymore, but but I haven't given up on medicine. I still believe that we can get back to medicine that's better, that's one-on-one between a physician and the patient, negotiating care according to their values.
So I've had several doctors on this podcast who feel exactly that way. So they don't take insurance. They just charge cash. Is that the route that you see happening if independent medicine is sustainable?
That's one way. Um, that, I think that may be the immediate step that we need to take while we're trying to negotiate these other changes so that people have some relief, so that patients can get access to the kind of care that they would like to have too. And by the way, cash pay doesn't have to be as expensive as as what you would pay with insurance, right? It can Direct primary care can be a very affordable option. Um,
Definitely.
but yeah, I think it's a stopgap measure that probably will not be the final answer, but it can work in the meantime.
Right. I think it's like health itself, right? There isn't a cure all, but there's small incremental changes, and I loved your positivity at the end of that, where you still had faith in medicine. I love that, and I agree. But I think that there's not a cure all, and there's just things that we all need to do to make those small incremental positive changes.
Yeah.
We
I mean,
need
I say all the time that I could not do the work that I'm doing if I weren't a relentless optimist, feeling like that we could make change. Because otherwise, like there's so much that needs to change. I would just sit down and throw up my hands and say, okay, I'm done.
Well, I'll tell you just something with working with the legislators. You said we need to create legislative change. And I actually just posted this morning on my LinkedIn to ask Governor DeSantis to nix a bill that was passed by our legislature because it is going to increase medical malpractice rates for doctors. And it is not capping litigious claims, malpractice claims against doctors. And it's not even the person. It is extending it beyond if the person, once the person has died, their estate, their children, their, I don't know, great second stepdaughters, ancestors, whatever, can file a claim. And we already have the highest rates in the entire country. And most physicians in Florida, at least in my area, go bare. And so
Right.
we have all of these lawyers in Congress and all of these lawyers in our state legislators. We got to get doctors involved.
Yeah. Well, so it's really interesting. I've had physicians when I ask them to do that, they'll say, "Well, I don't know how to do that." I was like, "Look, you know how to write a soap note." They're like, "Yeah, what's that got to do with anything?" I was like, "Look, you put in different information, but the soap note is your structure. So the subjective is the heartstring story that you tell about the patient or about your own life and why this matters so much. The objective is everything, all the data that you can bring to this fight. The assessment is, what does this mean? How do I tie it all together? What is it going to look like if we don't do anything about this? Where is this headed? And the plan is, here's my ask. Here's what I want you to do. We all know that structure. It's like second nature. So just put in the different information, and you've got your conversation with your congressperson right in front of you.
That's an amazing metaphor that you came up with.
You specifically tell physicians that they have to bet on themselves, and you shared a little bit about that just now with creating a SOAP note. How can they do this going forward to bet on themselves? Physicians are highly independent. What can you say to encourage physicians to bet on themselves more?
I think they can, the ultimate way of betting on yourself is to walk away from employed practice, right? And set up your own practice. You can still bet on yourself while you're employed, but it means learning how to speak up, learning what the political environment is in your healthcare system, knowing how to communicate in ways that other people can hear. So kind of and educating yourself about what the business side of healthcare is facing, because you're right. It's not like we're the only ones facing challenges, right? We're trying to keep our patients alive. They're trying to keep the organization alive. How can we work together to do both?
Are there enough hours in the day, Wendy?
Yeah.
Okay.
I mean, there's plenty of information out there in various types of in various media. We've got 2 podcasts, I've got a book, I've got articles galore on our website. All the information is there to learn. If you do it 10 or 20 minutes a day, by the end of the year, you've learned a lot. A lot.
And if people want to hear more about what you have to say, share information about your podcasts.
Yeah, so the one that's active right now is the 43cc podcast, The Truth About Healthcare with a Shot to Dull the Pain. It is not safe for work. It's not safe for kids, but it is entertaining. And we go deep into all kinds of things: private equity, corporate practice of medicine, human connection, the Crozier debacle, the Stewart debacle. So it's kind of an entertaining way to get your information. The Moral Matters podcast is a little bit more academic. We have sunsetted it, but we had 8 seasons, so we've got 80 episodes. It's ridiculous. And then If I Betray These Words. And you can find everything on the website, which is fixmoralinjury.org.
And Wendy, I just want to thank you so much on behalf of Mike and me. I really appreciate you sharing your story, being honest, being a voice for doctors, being a voice for patients, because they're one and the same, and being a voice for the positive, because together we can create this change. So I really appreciate it, and thank you.
Yeah, 100%. Thank you so much. Great conversation.
To everyone listening, the full video of this episode is now available on YouTube. Just search Working Healthcare and hit subscribe so you don't miss future interviews, roundtables, and behind-the-scenes moments. And if you've got a question, an episode idea, or someone you think we should feature, drop us a line at meredithhirsh.com. That's HIRSH, no C.
And if this conversation hit home for you or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post it on social. You can follow us at Working Healthcare on Instagram, Facebook, YouTube, and LinkedIn. That's where we keep the conversation going between episodes. The more voices we bring into this space, the more momentum we build. Because change doesn't start with a policy. It starts with a conversation, a real one like this.
We're proud of the community we've built this past year and even more excited about what's ahead. So if you're just finding us, welcome. And if you've been with us since day one, thank you.
New episodes drop every Tuesday, and trust us, you won't want to miss what's coming next.
I'm Meredith Hirsh.
And I'm Mike Chavez.
And this is Working Healthcare.
You ready? You got me running, got me running.